Okay. Well, top of the day to Implant Compare World. Welcome to our operatory. We're going to be placing 3 implants today and most likely doing some bone grafting. If by chance the bone hasn't healed, ideally from the first bone grafting at the time of the extraction, we'll actually abort the implant placement. We'll just do the bone grafting today. So either way, you should get a good eye full of good information and great little procedures. The 3 implants that we're doing today are in the 13, 4, and 8 position. So we've got good visibility for the cameras, so you'll be able to get in there and good and see. At any time during the process, feel free to, in the little interactive window, text a little message, a question if you have any questions, especially about techniques and or instrumentation, and we can discuss that as we go so that you guys can learn as much as possible. So John has already been anesthetized. What we did is we used Septicane. It's all 3 are in the upper, so we used Septicane, and we just infiltrated all around the arch, so he's good to go. The first thing we want to do is assess the soft tissue. And without doing that with a rather blunt instrument, sometimes we'll use a periprobe. A curette will work as well. So if you'll note here, I'm looking for where the mucogingival junction is. And so as I roll this soft tissue here, I'm looking for where that tissue ends. There's my mucogingival junction. So I have a good band from idealized location. If I draw a line between these 2 teeth here at the zenith, I'm pretty close. I'm probably got about 2 to 3 millimeters of tissue there. However, there's a sculpted defect that you probably can't see on the camera this way. If I use my big mirror, you might be able to see it a little bit better. So if I place this in here, and you see that facial defect there? That's my concern. So when we were doing the digital workup, we were able to get by the way, these are all guided placements today. We were able to get the implant secure in the bone on the lingual, the mesiodistal, and apical aspects, but on the facial, it looked like it might have threads that were exposed to the air. So in that case, we would want to do a veneer graft. So the question is when we do this case today, if we can get the implant in, we'll just veneer graft over the facial of the implant. If not, we'll just do a veneer graft, close it up, let it heal a little bit further, and then come back and do it again. And the same situation kind of exists in these posterior. If you look in the posterior regions, in the premolars, you also have a buccal defect in both locations there that we need to manage. Okay, so that's our starting point. So the first thing I want to do is start with my 15, and we're going to just do a mid-crestal. And I'm going to come over here onto the facial here. And for this plan today, I'm going to do intrasulcular here. For the plan today, our plan is to do the bookmark technique. So no vertical release in the anterior zone. Going distal to the canine here, what we want to do is we want to make an oblique reflection here, and then just intrasulcular continuous here. And John, remember, at any point during the procedure you have any discomfort, just raise that left hand. Carefully, don't hit the table above you, but carefully, and then just wave it around a little bit, and I'll stop, and I'll give you some more medicine. Okay. So that's those 2. While we're at it, we're going to go ahead and do the posterior ones. Now, if I had ample bone and ample soft tissue, then for this procedure we wouldn't be doing this at all. We would be starting with the guide, and we would be simply using a tissue punch to create our access for our implant. But since we had these buccal defects here and a little bit of a loss of bone there during the healing process, we're going to do these reflections. All right. So we're coming in here with our Malt 9. And so we got that tissue reflected there nicely. Here we're going to come in.
once I get it started with the sharp end of the molten iron, I like to go to the beaver tail end. Prevents inadvertently going too far apically. So you can see we didn't grow idealized bone in this region right here. I'm going to come in with my curette and just make sure we don't have, what we actually did is we grew some soft tissue invagination there. So we had some soft tissue invagination into the site, not bone. Okay. All right, can you guys see that clearly? Good. So at this point, because of that soft tissue invagination and this rather large defect, I'm going to abort on the implant in the anterior zone. We're going to do the bone graft. We're going to let this heal and come back and place the graft or place the implant later. And we've already discussed these options with John before we started. And we knew this when we were looking at the CT scan that we had a problem. Let me look at this one over here real quick. The premolar we might be able to get. Let's see over here. We might be able to get this premolar as well. So what I will do is I will go ahead and seat the guide. Now I'm not doing a whole lot of elevation on the palate tissue because I made the incision a little bit sheeted towards the palate. And that way when we deflect the tissue, we deflect more of the keratinized attached mucosa down into the vestibule. And we call that here the Gumdrop Technique, but it's a Gumdrop Technique for a coronally positioned flap. So we're changing that to the AGD technique, the apically displaced gingival margin. Okay, so what we're going to do now is we're going to place the surgical guide in place. This was fabricated by Vulcan, and note that all the sleeves are color-coded. They're all 3 green. So all of these implants will be using the same sleeves. We've talked pretty extensively in our previous videos about the guided system, so I'm not going to spend too much time talking about that today. If you guys want to know more about that, then check out our previous videos because they'll have more details there. So what we're going to do is we're going to actually do the osteotomies on the premolar sites to see if we're in the right position. For the premolar sites, we have drill lengths of 21. So I'm starting with my drill length of 21, verifying that the saline solution is primed. Put it inside the master cylinder in a big opening, John. Thank you. And wiggle it until it's in position. And then that's how much, I'm just touching the bone there. So you can see we've got a good 7 or 8 millimeters of bone. And then we're just going to drill. So we're going to do both sides. Now, my assistant's wearing pink gloves, so you guys can see what's going on there. I'm not sure at this point whether or not we're going to be able to get those implants or those premolars, but if I do the osteotomy, if there's any bone chips that are coming out on the flutes of the drill, we'll capture that. We'll use that for an autogenous graft. And this one's looking pretty good, so if I can feel that, and I'm starting to get a little bit of bone chips in the flute there. This one here felt very, very light to me when we did the first one. And once again, you can see how far I'm dropping down there. So all we're doing is stepping through the protocol, and we're increasing the diameter. The length of each of these drills is the same. It starts with a 21 and it finishes with a 21. And what we're doing is we're simply stepping. So there we go. So we got some good red tissue right there. That's exactly what we wanted. We're going to try to capture this in our little dapping dish here in case we need it for our autogenous grafting purposes here in a second. All right. go to the other side. Four is in pretty good shape. I'm still not sure about 14. 13. Okay. Okay, now it's starting to feel better. Last one.
It's already right here?
Last. Are these 4 twos?
Yes, I'm just getting ready.
Okay.
Go and change your settings.
I have to drill still.
Oh, sorry.
Yep. I got one last drill. My assistant is faster than me. She's ready to go. So this is the last drill. And sometimes you can actually use the last drill to gauge your outcome. So I'm giving it just a little bit of push, and I note that I've got about 4 or 5 millimeters of engagement there. Still not great, but it does adhere to our 5 millimeter rule. So what I'm going to do is drill this one. We've got some good bone particles there. That looks good. So this one's looking pretty promising.
Dr. Rob, we have a question.
Yeah.
Do you prefer a key system rather than a pilot guide?
So I like what we call a Type 4 guided system, Type 4 being fully guided. With a pilot guide, if you're referring to a 2.0 pilot guide, when you drill that first 2.0 hole through your guide, it's very accurate. All your subsequent drills that you use from the 2.0 up to, in this case, a 4.1 millimeter drill are unguided, and then the placement of the implant's unguided. And then there's the problem that one might encounter is that the palatal bone is usually pretty rigid, pretty hard, and the facial bone is usually a little bit thinner. And the drill will walk, it will wander. It will kick off those hard spots and go to an undesired location. And oftentimes you see these implants, I'm sure no one's done one, but I'm sure you've seen one in your office, where the implant is tube facially placed in the anterior in the aesthetic zone. And you say to yourself, how did that happen? How did the surgeon who placed this implant end up having an implant placed so far to the facial? And most of the time the result is the result of not using a fully guided system, and the drills and the placement of the implant will kick out towards the facial, and you'll end up in a malpositioned implant. Okay, let's do this last one. So I like a Type 4 guided system, fully guided. All the drills are included, watch your finger there, as well as we're going to place the implant through the system. So we're changing the motor right now. We've got the Bien Air motor system here. We really like this a lot.
So here's 2 and 2.
Which one is 3 for 4?
4.
Okay, good. So the team has set up the drivers for me. And, well, if you don't drop them, they're really helpful. So we set up multiple drivers for different purposes. Some of them are subcrestal, and some of them are what we call the original design, which are just full. I like to start with the fulls and then go to the subcrestals if needed later. In this particular case, we definitely don't need it because we don't have a lot of bone around the crest. Once we pick up the implant, we hold the implant. We go into the close-up here. You want to hold the implant like this, upside down, as I carry it to the mouth. It prevents the implant from inadvertently falling off the driver. So it's color-coded, and it has a stop position. Okay. So we're going to come into the back of the mouth, and then we come forward. We engage the site, and then with light apical pressure, not a lot, I want the implant to pull itself into the socket. Okay, so we're in position there. And then let's take the guide out. And let me evaluate the other side, because I'm still not confident that we have all of the tissue I need here to do John a good implant. Pardon? Yeah, a little section, and then we'll show them in there. So I have in this quadrant on the tooth number 13, I'm going to reflect this tissue here and give you a good view of this. Section in the hole. All right, let's see if we can give you a good hole here. All right, so what you can see here is that basial distal is intact, palatal is intact, but the buccal is not intact. So I have to make a decision here, and I think that I can actually get stability on this implant and graft the facial in one appointment. Now, this is really a judgment call. It's a 50-50 call in this particular case, but I think I have enough bone apical to where the defect is to do primary stability and then graft around it on the facial. So we're going to go ahead and try that and see if I'm right. So this one.
It's already changed.
Thank you. The stop positions are being called out by my team members off the back wall. We have the surgical sheet that tells us what stop position needs to be. And so here we go. There's our implant, our driver, and our stop position. In this particular case, stop position 4.
All right, let's
Put the guide back in, yeah. Helps if the guide's back in.
I was like, what's missing?
All right. Guide's in. And it doesn't engage. So it does not engage at all. So we're going to abort on this one here. And what we're going to do is we're going to graft the anterior and 13. Yeah. So we never go in the mouth, and I mean never go in the mouth without a throat screen protecting that airway. I see so many people going in the mouth with these small little parts, and all you're looking at is one inadvertent drop, and that patient's off for a chest x-ray. And nobody wants to have that kind of day. Just light pressure with this finger and creating a rotating force here. Not heavy. This is a threaded system. It will thread itself in passively. No forces are required here, okay? So light twisting here, apical pressure here, very, very light, and now it's firm, and that's it. I don't need to torque this at this time. These are machine parts designed to go together. There's no concern about bacterial infiltrate between that abutment and that implant at this point. So we can graft the facial here, we can graft the facial there, and we're going to graft the facial here. Jen, we may need another memlock. So for our grafting procedures, we're going to use a couple different things today. We're going to use Mineros, which is a cortical cancellous allograft. We're going to use Mineros X, which is a xenograft. And then we're going to use a Memlock, which is a cross-link collagen membrane. I like the cross-link collagen membrane because it stays around longer than the non-cross-link collagen membrane.
So if you want to cut this and use it in 2 different places, since it's a 15,
Yeah, let's see how it looks.
then we don't have to use another one. So straight scissors are right here.
So these are some of my tissue pickups. These are my smooth ones. They don't have any teeth on them. They're great for handling your collagen membranes like this. The reason I want to do a collagen membrane is I want to prevent, close down just a little, John, that's perfect right there. I want to prevent that soft tissue invagination that he had in the first case. So this is looking pretty good. I think we can get by with cutting this in 2/3.
Do you need more than a half cc of Mineros?
No, a half cc of Mineros and a half cc of the Mineros X.
It's a half of a gram for the Mineros.
I'm sorry, what?
It's a half gram for Mineros X.
Okay.
It's a little bit more, a little bit less.
All right, so I just sized this a little bit smaller for this region right here. And what I'm going is from the distal of the central here over about halfway over the canine, because I know that's where my defect is. And that looks pretty good. Now, what you can do is you can come in here and just cut these corners off if you're concerned about the sharpness of the corners. And this material is pretty pliable. When it gets a little damp, it's usually in pretty good shape. Now, before I start this, what I'm going to do is I'm going to grab my other pickups. These are my 2-in-1 pickups, and I'm going to score the periosteum so that we have a nice passive closure. when we're done with the case. So we're going to come up in here. We're going to verify that we've got a good primary release. I'm just using a 15 to score the periosteum so we get a more plastic, passive fit. Hey, the hemostats, please. And there's just a piece of granulation tissue right here. I'm going to get that out of there. Right there. Good. And that's good there. So now, see how passive that is? I'm not putting a lot of tension on that. So when I bulk this out, I want to kind of have a passive fit. I don't want to put any tension on this. So that's looking good there. Good. I don't really need a passive fit over here between the lateral and the canine because I'm not grafting there. So I really don't need one there. And then we'll get one back here. I'm going to try to look in here without getting in your way. How's my head there, Margaret? Good. Okay. And once again, we're just scoring the periosteum with a 15. That's good there. And that's good there. Okay.
What is the resorption time for the Menlock?
The resorption time varies based on patient to patient, but in the literature, the literature that comes with the product, it says it lasts as long as 4 weeks, which is plenty. Yeah. No. Give me the allograft first. So what we've done is we've placed this out on the facial. So the Memlock is going to be a barrier between the soft tissue and our bone graft. And I'm getting pretty good bleeding here. So oftentimes in these cases, you need to go in and initiate bleeding with some regional acceleratory phenomenon while placing some holes on the facial. But in this case, I don't feel like I need to do that because we actually are having pretty good success here. I just keep pulling the graft out, the membrane out. Okay, good. So what we're going to do is we're going to put a little sealing. I got some in our graft, and then you have, this is that's the graft. Yeah, so I want the allograft, the autograft first. So we're going to take what we had from the osteotomies, and we're going to graft that first into the socket. And this is our more significant grafting is in the anterior here. So this is our primary focus. This one obviously is doing pretty well. The implant's in, and the other one on the 13 needs a little bit of work too. So right here where where that soft tissue had invaginated into the graft, we're going to come in here and use our autograft, which is our gold standard for grafting. So you can't get any better than autograft. It has all the growth factors that you need to grow bone because it is bone. All right, so we didn't get a lot, but we got a little, so that's good. So we'll come in with a gauze, and we'll just dab, and when my assistant applies the gauze to the field, I just push on it a little bit to give a little pressure. And you can see there's our autograft right there. So not a lot, but a little bit. The next layer that we're going to use is we're going to use mineraloss, just regular mineraloss. This is corticocancellous chips. This is an allograft. So we do the four-handed technique. The assistant brings it in with one spoon. I slide off, and then we need another. And that's good there. Let me take a look at this. So we're going to get this into play here. Now we're going to do something different on top of this. And so I'm going to get a little bit more apical. Let me get like a half spoon. And see how that soaks up any sort of fluids that are in your surgical field, and you can see your graft tapping on it lightly so that the particles kind of seat. That's looking good. Now what we're going to do is we're going to go with a layer of xenograft on top of this. Now the xenograft is going to hang around a long, long time. And the purpose of it, ooh, that's a big spoon. I think that might be all I need. Yeah, thanks. The purpose of the xenograft is not structural in this case so much as it is aesthetics. I want this to be plump and full so that it mimics the natural contours of the alveolus. And so that's what we're using that for. Just on the outside. So underneath that we have, the first layer was autogenous graft, and then the second layer was the allograft. So that will turn into bone with time, and that's where we're going to want to place that implant. So very carefully, I'm going to come out, and then I'll take my suture. I'm going to use a non-resorbable suture today. We're going to use a 6-0 polypropylene suture, so I will have to retrieve this. When I do perio surgeries like this, periodontal surgeries like this, I like to use non-resorbable so that we don't have any inflammation issues. I'm okay for now. Let me just grab this here real quick. So I'm going to I got it. I'm going to do a horizontal mattress right across the face here of my a little water in here. Now the driver I'm using here is a Casta Viejo driver, and I like this because it allows me to get my action with a rotation of the fingers rather than a full wrist motion. So a lot of times this is for some delicate work. I like this a lot. I'll take the 2-in-1s if you would. It's kind of weird working in our operatory here, our surgical suite, without our music on. We turned it, yeah, we turned it off for the purposes of the video here so you guys can hear what we're saying, but it's just very strange to have such a quiet environment. So, 3 throws, not 2. So I got a little bit of fluid in here. Jen, yeah. So when we're working with these micro sutures, if you get a little bone chip between your pickups here, it's hard to grab the suture lines. So 1, 2, 3 throws, not 2, for these polypropylene ones. And you can't put a lot of tension on these because they're so small. So I'm going to let that first one lay flat. And that's looking pretty good right there. And then we're going to follow up with 1 to the left and then 1 to the right. So instead of a 2-1-1, we do a 3-1-1 throw. Okay. So now what I'm going to do is do a sling suture around the canine. And sling suture is one that we didn't get in dental school, but I'll tell you what, we use it all the time. Actually, before I do that, I'm going to go ahead and secure this vertical. This vertical release, I'm going to go ahead and secure this first. And the reason I'm going to do that is if I put that sling in there, it would have pulled that tissue, and I would have had a hard time getting this tissue back here approximated properly. So
They're asking for a suturing webinar.
yeah, that would be fun. There's a lot of neat little tricks that you know that I don't know if I was sleeping in dental school or what, but subsequently when you get out, you learn all these tricks. You're like, well, why didn't they teach us that in dental school? Because that's a really handy one. In particular, this sling suture. So 3 throws. I'm not doing it right now. I'm just doing it interrupted here on my vertical release to approximate this tissue prior to doing the sling, because otherwise it wouldn't approximate very well. Yeah. Now, I usually like to leave the tails on these polys about 1 centimeter. And at the 6/0 size, we don't normally have people worried about the poly poking them. As you go bigger, as you go down to like a 5, definitely if you go to a 4, your patients are going to complain about that suture tail poking them. And the reason we go a little longer, so now you can see this is approximating the lateral here quite nicely. So I'm going to come in to the line angle on the distal here, 3 millimeters below the desired free gingival margin, and I'm just going to make my first bite there. Okay, and then we have not assessed. If we were doing like aesthetic crown lengthening or something like that, we would have assessed all of the contact points. Assuming that he's got a contact point between this lateral and the canine, we're going to pass it from the face, not trying to engage tissue, and then the assistant passes it around to the mesial, and then we're going to pull it through. Okay, and so I'm now going to take a bite that is going to be 3 millimeters below the free gingival margin and on the mesial line angle of the tooth. So I'm going to take a bite here. The tooth is about 7 millimeters in diameter at the thickest part there, right? So you can see that my 2 purchase points here are about 3 millimeters apart. Let me just get the tail here. Good. Make sure I got there's my tail. So we're going to pull this through a little bit at this point. Okay, and now I can hand this back to my assistant. She's going to pass it from the lingual. She's got a better view of the lingual over here, so if you grab that and just pass it through on your side. So when she passes it through, I grab it, and now what we've essentially done is we've slung around the tooth, and we're using the tooth as an anchor point for the suture. And that's what's so great about this, because you can use this suture around implants, you can use this suture around teeth.
You have to pop the tooth on that one, don't run. You came out.
Did I come out?
Yeah, you just have to pop it close.
Wait,
You make them
no, I
almost-
didn't.
You
Alright.
did? You
Yep.
just wrapped around?
Yep. Good. My assistant was being careful that I hadn't popped through. And so I don't need to tug on this too much because it's already approximated quite nicely, so we're just approximating it lightly. Go ahead and dab that a little bit so they can see. Okay, so you see that I'm not pulling too hard. I don't want to pull this up higher than where it was. Okay. Okay. Okay, so that's a sling suture. So we did a horizontal mattress, we did an interrupted, we did a sling, and that's looking pretty good there. And what I'm going to do is I'm going to assess the situation right here on the mesial here. So just a little dab right here if you would. Okay.
That's beautiful.
So I'm lightly tapping on these bone particles on the coronal aspect here to get them to seat just a little bit more. And if they don't, I'll just take 1 or 2 of them out so that I can get a little bit better closure here. So I'm going to take 1 or 2 just right off the top here. Just like that. You see that, guys? We're just taking a couple of these out. I just don't want them hanging around. People start to get a little worried when a couple of granules of these come out after the case. They think that the whole graft is coming out and kind of freaks them out. So better to just keep it right below the tissue there. So that's looking good. So you probably know what I'm going to do. I'm going to do a sling suture around here to grab this tissue here and help bring that in. It's just a stronger than if I was going to do like a vertical here. It's just a stronger suture. All right, So now, because I'm on my side, I actually have a better view of the lingual here than my assistant. I'm going to pass, and if I needed, I would have her catch, but in this case I can see it quite readily, so I'm going to grab it. Oop. It came through on the lingual, or on the initial. So what we'll do is we'll hang on to it this time. So, Sarah?
Yes.
I'm sorry, Jen?
Yes.
Can I get another suture, please?
It's a 6-0 poly. It's on the very far right.
So, if you can see that on the camera there, my pickups are a little bit magnetized. So sometimes we're struggling with the magnets. Okay. So the reason I asked for a new suture is right on the tip here, I've inadvertently blunted the tip of the suture, going in and hitting straight onto the bone like that, probably. And so I'm going to go ahead and replace it for the next subsequent sutures that we need to place. Okay, so I've got my 2 purchase points. I'm going to pass through again. This time I can see it better on my side, so I'll grab it. And then there is no mesial, so we don't have to worry about that. We do have to make sure I don't hook my my line here. So there we go. So I don't want this, if you'll note here, notice right here, guys, this suture is on the distal of that papilla. I don't want that. I want that to be on that side, on the mesial side. So when I give it a little tension, it drops into that mesial sulcus there. Good. I'm going to shorten the length of my suture. So I don't have as much tail there. 3 throws. And see how that closes up quite nice. A little gauze on the coronal there. Yep, thank you. Good. Okay, so that's it. I'm probably going to throw another suture right on the mid-crestal there. The first one, the first horizontal mattress, isn't quite tight enough, I don't think. So I've placed the tip of the needle. When I'm done with the needle, I place the tip of the needle inside the hemostats, or the drivers, I should say, so that if anybody inadvertently touches this, they won't get hurt. And then we also say needle down and place it usually in a kidney tray. For our bigger cases, we have a kidney tray up there filled with some saline. So that's good for now. I'm going to probably come back and put another one right in there, but for the sake of time, let's go ahead and start on the graft on this side over here. So first thing I'm going to do, and John, if you could turn a little bit towards me. Thank you. And Margaret, is that, okay, so this is a little bit challenging team for you guys to see. A little suction in the hole, please. I've already had released the periosteum here, so I've got a little more of the cross-link memlock. Okay. Yeah, that's right. Actually, this one we could probably just do almost all mineral loss. Okay, let's try that. All right, so as Sarah brings the graft, she's going to bring it back to the mesial of the molar, and you'll see why. She's going to bring it back to the mesial of the molar, not up here near the premolar, but back here. And when she does, I slide right off the top into the hole. And we've just found that so far we haven't found a way to get this in any easier than that right there. And this is a double-ended. Okay, this is a double-ended instrument, so you can see on the other end it has a condenser for condensing, and the one end it has a giant scoop. Okay. Yep. Yep. One more. Yep. All right. Good. A little lot there.
It's hard for me to get right up in there.
All right, that's good.
6 verticals left.
let's save it for the other side, and we'll just do it on the facial there. So for this one right here, we're going to go ahead and close up here.
Do you want anyone?
Yeah, that'd be great. Jen, where's that sharps?
Just set it on the counter.
I'm going to set it right here on the magnet. Okay. So we got a new 6.0 poly for this site back here. And I'm going to come in here. Yeah. I can't see it. There it is. Okay, thank you. Well, we just pulled the graft right out through the suture. So I'm going to get my other pickups here. And I'm going to just temporarily hold that out of the way. I'm going to use that in a second here. And so we're going to take our bite on the palate. So the trick is to do these procedures in the best way possible so that you guys can see, which usually puts my back in a precarious location. Yeah. Okay, so. No, it's hanging up on something. I think the graft is hanging up on it. So the suture is, yeah, the tail here. So my tail had made a little inadvertent loop with the suture there. So now what I'm going to do is I'm going to seat that graft back in position. I'm not the graft, guys, the membrane. So we're going to come back here with the membrane, and yeah, these are fine. I'm going to get that down in there on the facial. Okay.
Do you want the tissue pickups or the straights?
These are fine. Jen,
Yes.
can I get that kidney tray with some water, please? Spray that again if you want. So I got another graft particle in between my castros. So I have these in, they're actually come in different sizes. The short ones are, there's another piece of, no, it's in the fluid. The short ones here are called castros, and the large ones are called Jacobsons. And the large ones are like 7 inches long, and these are like 5. And I have a set of each. Because I like these so much, I use the Jacobs for wisdom teeth for suturing in the posterior. And I use these shorter ones. As you can see, they work quite nicely up here in the anterior like we're doing. Okay. Thank you. All right, let's go needle down. Let's go to my side over here. Okay, come back to the middle now, John. Thank you. So on this side, I'm more interested in getting kind of just some bulking, so I'm going to use more of the xenograft. Mm-hmm. And there's my plugger.
Can you have all first?
I'll get it. Be careful, don't put any pressure on the implant there. Okay, swipe off and then down on the facial.
That one's good, huh?
Okay. One of the things that we're doing here is if you place your implants at the proper depth, what you'll find is that you actually are future-proofing these implants in most cases for future. Turn back towards me. Thank you. For say, for instance, a full mouth restoration. So when we're done here, we'll have 3 implants in the maxilla, and everyone's probably experienced a case where a patient's had 1 or 2 implants placed throughout their life, and then they're getting to the point where they might be a candidate for a full arch solution, screw retain, for instance. And then when you do the workup, you realize, okay, that the implants weren't placed deep enough. They were too apical. I'm sorry, too coronal. And therefore, you have to retrieve those implants, even though they're integrated. You have to retrieve them at the time when you go to do your full mouth restorations. Now, in these cases today, when I was doing John's workups, prior to today, and when we did the workups, we made sure that the implants were placed at the ideal position for aesthetics in terms of depth, but also that they would be capable of being used for screw retained in the future for full arch. And that's really clever. So the BioHorizons implants that we're using today, the suture cap, or I'm sorry, the healing abutment has a little groove in it. The groove is designed to capture sutures. It's a pretty clever idea. So what I'm doing here is a horizontal mattress, and let me just show you in the mirror before we get too far down here. I've just looped around. Do you see the little loop right on the top of the implant there? Let's see if I can get the angle right. Right there on the top of the implant, it's not on the lingual yet. I'm going to move it to the lingual. But if I show you the side, you see right near the side of the head of the abutment there, there is a, yeah, lightly, perfect. There's a little groove right on that suture cap. So we're going to engage that, and that's going to be like a sling suture, but instead of around a tooth, it's going around the abutment. So let me make sure I get... Yeah, I'm blowing it. I'm going to find my suture here. Okay. So now I'm engaged around the head of the abutment. And what's nice about this is if you watch carefully, when I'm done, I will have displaced the gingival margin here, the keratinized tissue on the buccal, down into the vestibule. So I got another piece of debris. Apical gingival drop. Displacement. Apical gingival displacement. And so I want to make sure we get these. And we use this almost on every case because it gives you a nice band of keratinized tissue on the facial that you would not otherwise have in many, many cases. And we want to make sure we got a good 3 millimeter band around that facial. Okay. Now, let's come back and take a look and make sure we don't need any last minute. Yeah. So let me see that gauze for a sec. I'll go ahead and get ready for that PA on 4 if you would. And yeah, I'm going to do another suture right there on that one. Let me check the occlusion over here. The occlusal view there looks good. So just a little bit on the number 8 position. I'm going to put another horizontal mattress in the center there. And this looks really good. Let me show you what we're talking about here with respect to this AGD technique. So if you notice, the implant's in. Let me get a really good angle here for you. There. So you notice the implant is centered right in the central developmental groove, just like all of the cases that we do when they're guided. They're right where they should be. The graft is on the facial, but notice the keratinized tissue on the buccal. On this side over here, on the buccal side, notice that it's pushed down into the vestibule there. So we're pushing that keratinized tissue now. There's a gap. You're wondering, there's a gap. It's like 3 millimeters wide on the mesial and distal of the implant. What's going to happen there? It's going to heal by secondary intent. And what's it going to grow? It's going to grow keratinized tissue. So when this is done healing, he'll have great keratinized tissue surrounding this implant. Give him a really long-term solution. All right, so we're going to step out of the room for a second. We're going to grab our radiograph. So we took our first radiograph and we're missing the apical aspect of it, so we're going to take another. All right, perfect. So do we have our free-handed camera? We'll bring the, can you keep that up, please? Oh, you're gonna pull it on the computer? Okay, so great. We'll show you what that radiograph looks like. Really good. Right here in a second. It looks really good. It's buttoned right up against the bottom of the sinus. That's right where we placed it. Yeah. Let me get a little water here. A little water here. Thank you. And let's clean up this. Be careful around that graft. So just using a wet gauze to clean up the field here so you can see a better what we're working with. Yeah, so you can see that. Let me just show you right here on the central location here. See how that buccal is all filled in now? Let me get this. There we go. So the buccal is filled in nicely with that graft. And since we did it with the sandwich technique where we've placed that xenograft on the outside, it should really maintain that volume quite nicely for us. Okay, so there you go, guys. Right up against the sinus, centered between the molar and the first premolar. We got that one looking really good. The other two, like I said, it's never worth racing to try to overextend a situation, and if you have a delay like an invagination like we had, it's not a big deal. You just want to do right by the patient. It does require a second procedure a couple months from now after they're healing, but it gives the patient a really great long-term solution that they really appreciate. All right, I'm going to do one more suture in the anterior here. So right in this region here, I'm not loving that closure there. I want a little bit more. So these Castros and the Jacobsons, you can get these from, you can get them from Hugh Freedy. I like Hugh Freedy's products because they're made with good quality German stainless steel, but they're also an American company, which I think is nice in a time when it's challenging to find hardly anything made in the States anymore. So got a little bit of a bend in the shank of the needle here. It's hanging up a little bit. It's no big deal. So normally for these cases, it would just be me and my primary surgical assistant. Today that's Sarah standing beside me. However, when we do the full mouth cases, the full arch cases, we've found over time that it's really helpful to have a dedicated second surgical assistant with you the whole time. And that drives down our surgical times. We're doing full arch solutions now with a guided in synchronous protocol in under, well, in an hour and a half. So including removing the teeth, placing the implants, placing the long-term provisional, and taking the gloves off and sending them home. So that is what we call a practice builder. When we can provide a screw-retained full arch solution in an hour and a half from starting with terminal dentition. And we've got that class coming up here in the fall. All right, so just to show you, we're going to get a little dab of periacryl.
Yep. You want to give them a shot real quick?
Yeah, before I goop them up, yep, let me show you what this looks like here. There we go. Let me get my finger out of the way. So there's still a little gap there on the mid-crustal, and what I'm going to do is I'm just going to dab a little bit of periacryl on there and let that liquid sutures fill in there. Now, when you use periacryl, this is very, very important. If you've never used it before, this is medical grade super glue. Do not float this in here and let it soak into your graft, because your graft is like a wick, and it will wick this glue right down into the salt, right down into your graft. It'll go down a few millimeters, and then if it goes down a few millimeters, you're not growing bone there. That will not grow bone there. That will slough off. So you'll miss out. So since we're using medical grade super glue in the mouth, we don't want John to glue his lip to his site when he leaves, so we're going to add a little Vaseline on top of this. So I just run a little Vaseline in the site, and I actually like to use my finger to spread it around a little bit. So we're spread around on the facial and then on the palate here, and that just prevents that medical grade super glue, the periacryl, from, no, I think we're good on the other ones, yeah, from gluing itself inadvertently. So now let's show you one last view of that one in the front there, so you can see what that looks like. So you can see it's well adapted now. So we're real happy with that. So we'll come back and place that implant in a couple of months with the exact same guide. So the guide will be reused, so we don't have to remake that or anything like that. If for some reason when we did one of these procedures we felt like that the initial design, the initial placement was off, we would obviously go and redesign. We'd just do a new guide. We wouldn't take that risk. But in this case, the bony architecture was intact, and we had that soft tissue invagination. Now you may be wondering, hey, how did you get to the point where you had that soft tissue invagination but you didn't know? Well, we did know on the radiograph, on the 3D scan. What we saw was, you can go ahead and set them up and kill the lights. What we did see on the radiograph, on the 3D cone beam CT, was a demineralization. So we weren't certain if John had just poorly healed from the original bone graft in the socket, or if he had soft tissue invagination until we did the surgery. Once we opened it up, we saw that invagination, then we said, okay, that's what it was. So we did see it on the scan. We just didn't know for sure what it was. So that's it today, guys. Thanks for tuning in. We appreciate you watching. And if you have any questions, shoot us an email at our on our website. You can go to info and just shoot a info@stanleyinstitute.com. Ask us any questions you want. We'd be happy to answer. Thanks for tuning in.